guys can't even. Okay, so put everything down for a second. Let's just take a couple of breaths. Ready? Hold it, hold it, hold it. And exhale. We're gonna do a couple more. Drop your shoulders, breathe in. And out. And all of you guys that are looking at me like, this is so stupid, why is she making us do this? You probably need it the most. One more breath. Breathe in and out. Everything is gonna be okay. Remember, you guys are really smart, you're really capable. This is a very small window of time, and everything is gonna be just fine. Okay? I'm telling myself this too. Okay. Tomorrow's Women's Health. How are we feeling? Oh, we're feeling bad. Well, good thing that the next part of this lecture has some of Women's Health in it, so I will help you study. We'll study together a little bit, okay? Let's review where we were. We started adolescent yesterday, so we finished up some of that abnormal development, started adolescent. So just to kind of get your minds back into a little bit. What is your first line treatment for ADHD?
Methamphetamine.
Behavioral therapy, behavior modifications. Remember, first line. But if I told you what's your first line medication management?
Meth.
Stimulants. Which one?
Meth.
Methylphenidate. Less like methamphetamine. Yep, correct. What are those two top side effects that you're looking for in children if you put them on a stimulant medication?
Heart rate.
Sleep and appetite. And why do we care about appetite?
Because they won't grow.
This is going to affect growth. Perfect. Which one has modifications, 504 plans or IEPs?
IEP.
IEPs. What do 504 plans have? Adaptations.
Adaptations.
That's a different one. Okay. So we're talking about all the things puberty. So jumping kind of back in. So we'll kind of mix male and female puberty here, but a little bit more. I know you guys care more about the female puberty as you're studying for women's health. So that's okay. So we said normal puberty goes through those 5 SMR stages, starting with 1, prepubertal, ends up at 5. So what are some of these variations, and when are they normal, and when are they abnormal? So pediatrics has a lot of normal abnormals, right? And the reason I'm saying normal abnormals is if it happened to you as an adult, that would be really abnormal. If it happens along the way for growth and development, a variation of normal. So first thing of a normal variant of puberty is breast asymmetry. So you'll get patients that will come in and say, one side looks drastically different than the other. So yes, it is like a horse race. They do not always grow at the same time and the same rate. So that breast asymmetry is very normal, as long as you do not have cessation of growth completely. When you're looking at how do I know what that true puberty was, I'm looking for a true breast bud. So that feels like a hard kind of pea-sized nodule that is directly under where the nipple would be. So that feels very different, and it is stimulated by estrogen compared to if there is no estrogen from the pituitary, from the ovaries, then you have no true breast buds. Those breast buds are tender. They can be very tender. And so if you have somebody that comes in for breast pain, a lot of times it is the first time that their little bodies are feeling what that estrogen receptor tissue and how it's responding and why it can be a little bit tender. All women will have some development or some degree of this asymmetry, so something to think about. When a child comes in and they say, I think I have a breast mass or I have breast pain, is this in her block with fibroadenomas yet, or is that her next block? Okay, you'll see that next block then. So I know you don't care about it as much, but there are normal cysts or benign fibroadenomas, and that can happen in young adolescent females as well. I have not seen a breast cancer in a true pediatric patient. So I know that you will hear sometimes that breast cancer is on the rise in younger women. That's typically in the 20s. And not just that I have never seen it, but by the numbers, you're really not going to have an adolescent that has breast cancer. Caveat would be if they have some family genetics and something that you might want to be a little bit more aware of, like BRCAs, but not something that you need to really worry about in this group. That said, low threshold to get an ultrasound. Ultrasound is going to show you really what is it, what are the characteristics of it, and it reassures a lot of parents. It's non-invasive, it is non-harmful, no radiation. You look like a hero. So a breast ultrasound is a hero's choice for all things breast complaints that are coming in. So it's likely not going to change your management, provides a lot of patient reassurance. Another normal variant in females is going to be physiologic leukorrhea. So there is some clear, odorless discharge that little girls will start to experience as their tissue, again, that is estrogen sensitive, is stimulated to make this type of lubricant. Very different than if you had somebody coming in for vaginal discharge and they were a little bit older, they told you there's a sexual history, or that there's pain, or that there's itching, or there's other symptoms. So this has no other symptoms other than this is the first time that this child has ever noticed this. So physiologic, so no odor, no itching, no pain, no nothing. For the love of God, do not put a speculum in this child. She does not need a pap smear. She does not need any kind of invasive pelvic exam. Very, very normal. So please don't do that if there is a history of a normal child. No speculum exams. If the patients are really worried about this and they are worried that it's an infection, you can take a vaginitis swab and have the patient do a self swab to run it through the lab just for a confirmatory. Makes everybody feel a little bit better, but it will be negative. So physiologic leukorrhea around the middle of puberty, SMR3, totally normal. Nothing you need to do about it. What about premature thelarchy? So true thelarchy would be if you actually had those breast buds and true thelarchy, but you're less than 8. So when was normal puberty for girls?
9 or 8 to 13.
8.
Yep, 8 is great,
13.
13 too late. When was boys?
9.
9 to 14. 9 is fine, 14, that's mean. So under 8 years old for a girl, not normal to have true breast buds. So not just fatty tissue, you'll sometimes see that with children that are a little obese, but true breast buds that are estrogen sensitive. So this child comes in, let's say she's 3, 4, 5 years old, comes in with true breast buds, but nothing else. She's not hitting a growth spurt, she's not having any odor, she doesn't have any axillary or pubic hair, it's just those breast buds. That can be a normal variant. Cannot be, but it can be a normal variant. So the natural history will be that she will be normal, but you gotta rule out a couple of other things first. So what am I ruling out? Well, I'm ruling out that the pituitary has already turned on and is stimulating the ovaries to start making hormones too early. I also want to make sure that there's no outside estrogen coming in. So is this family switched over and they're consuming massive amounts of soy, right? So look for that in question stems. If suddenly they have a radical diet change and they're not eating meat and there's only soy products in the house now, it's trying to tell you that there's some sort of exogenous estrogen component there. Growth charts are going to be really important here because you're looking for, is there a steep growth velocity change? When you get that, again, typically in that SMR stage. And then your lab and x-ray. So I want to look at a couple of things. Number one, how do you do a bone age? Yep. Picture of your left wrist out there, and you're looking at how much growth is left in those growth plates. So you're doing that, and then which one of those are coming from your pituitary, those labs? LH and FSH. What should they be in a child who is 5?
Low.
Low. If they're in precocious puberty, what will they be?
Higher.
High, correct. What should your estradiol be in a 5-year-old?
Low.
Low. In precocious puberty, they will be often higher. If it's an exogenous source, what will your estradiol be?
High.
What will your LH and FSH be?
Low.
Low, correct. You guys got it. If any of those things are out of whack, where you've got exogenous, or you've got your LH, FSH high, or a bone age that is not conducive. So if you look at this bone age of a 5-year-old that says that they're 7 or 8 years old, very concerning. If any of those are outside that normal, that's when you're gonna refer to endocrine. What I'm gonna tell you is I will put, especially for we get into block 2 and 3, after they refer to endocrine, there is some of the management that I will put there. I typically don't test on that. I'm not saying that I absolutely won't, but some of these are in here because if you are referring a patient and you're like, I'm gonna refer you to endocrine, and they say, well, what is endocrine gonna do? And you go, I don't know, then you sound dumb. Okay? You should know a little bit about what you're referring your patient for and why. So in this instance, endocrine is going to say, hey, do we need to screen? Is something on that pituitary that is stimulating it early? So I need to do an MRI to rule out that. What kind of MRI specifically do you need to get? What part of the anatomy? Where does the pituitary sit?
Head.
In the sella turcica. Yep, so your MRI is a specific sella series. You have to have a specific MRI for that will look specifically at your pituitary. Why would I need to do a pelvic ultrasound? What kind of tumor? On what organ? An ovarian tumor. The other one I will look at is adrenals. Is there something on there? I don't think that's going to make sense because those are typically male hormones, but something that I'm going to look at. And then the GnRH stim test. What is that doing? Yep, primary or secondary, up in the pituitary range. So, premature thelarchy can be a normal variant once you've done your due diligence to rule out that it is not abnormal. Okay, premature adrenarche. Now we're talking about those adrenal glands. So now these are these male hormones. So I'm not as much worried about the estrogen component now. I'm worried about why is there these increase in male hormones. So you can see this in both males and females. A little bit more concerning when you see it in females. Let me say that. So some of those male type symptoms. So body odor, pubic hair, axillary, acne. Where might you see acne? Back and chest, and then some of the shoulders. It looks kind of like you've robed them, like getting your doctorate, right? So in that same situation. Less than 8, less than 9, so before puberty would have even started. It's all male types of things, but you then see no true virilization. So you don't see the testicles enlarging, you don't see any kind of clitoromegaly going on. There's no, if I'm saying this, no breast development and no testicular development, that is not true puberty. So you know it's coming from somewhere else. Pituitary has not said now is the time. Oftentimes it will have to do with some CNS insult, or in more likely the case, obesity is the cause of this. It has turned on some of those adrenal gland production. This, for most of the time, has a good outcome again. So it's going to be another normal variant. Things that I think about, is this congenital adrenal hyperplasia? So are they missing an enzyme that is converting all of their adrenal hormones into this male hormone? So what lab am I going to check for CAH? 17-OHP, yep. So 17-hydroxyprogesterone. So I would expect that to be high or low in CAH. High.
High.
Yep.
Because they can't convert.
I have this byproduct that's going this direction because I can't send it down the correct path. 17-OHP is going to be high. And you're looking with an ultrasound, do I have a tumor that's pushing on that? Or then Cushing syndrome again. So your GnRH stim test can help you with that. Androgen exposure. So this is typically the way I've seen this tested and in real life of a little girl who now suddenly is having some of these male type puberty symptoms. So the patient that was in our clinic, dad was on an androgel, so a topical testosterone. He was putting it on his thigh in the morning and then picking baby up from crib before it had dried. So she was getting just direct testosterone exposure. So that can be your exogenous source of this androgel or testosterone, or if there's some sort of family history going on. So again, you're going to be looking at what's the state? Is this true puberty or not? Are Are they growing or not? And then your labs are gonna rule out some of those things. So is this congenital adrenal hyperplasia? I don't know, I need to get a 17 OHP. That's normal. DHEAS, dihydroepiandrosterone sulfated, something like that. That is produced from what gland? DHEAS. Dihydroepiandrosterone. What's your best guess? The adrenal glands, yes. So do you think in a premature adrenarche, is the DHEAS going to be high or low? High, yep. So for premature adrenarche, you're gonna see DHEAS high. Androstenedione and testosterone, are those going to be high or low? High as well. Going to be high as well. Bone age. High, low, normal? Normal. Correct. Pretty normal. Endo then, they will do some more additional labs to see is there stimulation from ACTH. So where does ACTH come from? After I'm sitting here. Pituitary, right? ACTH goes to the adrenal gland. So for premature adrenarche, do I expect ACTH to be high or low?
High? Low.
If I expect it to be high, where's the problem? In the brain.
In the brain.
Is this a brain problem? No.
No.
So do I expect ACTH to be high or low?
Low.
Low. Correct. You didn't know endo was going to come back to haunt you, huh? Premature testilarche. This one is the concerning one. So if you have a little boy less than 9 years old and you are looking at the testicles and examining this child during a well child or any other examination and it is more than 2.5 centimeters, that means that that is coming from the pituitary. That means that it is turned on the testicles to make testosterone, and that means it is a brain tumor until proven otherwise. Something has turned on that pituitary and it's not good. So premature testilarche, there's no version of normal for this. It is a brain tumor until proven otherwise. That patient doesn't go home until you've figured out when you can get an MRI for that patient, how you're gonna examine them, and that they have follow-up. So this is the one that I'm the most concerned about. Did Colonel Peter borrow my organometer last semester? Yeah. I had an attending in residency, real weird, used to wear it around like a necklace. Okay? Real weird. But that was how you can test testicular size. So if you are measuring the little bead next to the testicle to see what the volume is and what the size of that is. For the love of God, don't wear it like a necklace. Okay? Don't be weird. Don't be weird like that. But also, if it's an abnormal size, please check for a brain tumor. What about gynecomastia? So gynecomastia can be and often is a benign and self-limited part of puberty. I won't make you raise your hands, but by the statistics, half of you in this room, if you're a male, had idiopathic gynecomastia as a teenager, at least on one side or for some part of your adolescence. So just by the numbers. The things that make it reassuring versus concerning. So this is the part I need you to zone in on. So if half of these people that are coming into your clinic as teenage boys have this, how do we determine if it's normal or not? So normal, the reassuring, this is part of adolescence. It's a couple of centimeters, pretty mobile, tender, because it's hormone responsive, and no discharge. That is the defining feature. So star highlight underline that. If there is discharge from a nipple in a boy, that's not normal. Okay? If it's not painful, if it's hard and fixed, you can't move it, not normal. So please be able to distinguish, is it totally benign, this is part of puberty, it's tender, it'll go away, or I push down on the nipple, there's discharge, it's hard, it's fixed, not ever normal. Know those differences. The treatment is most of the time reassurance. Certainly if there are two things. So if it's hard fixed, if it has discharge, or if there's a significant psychological concern. So if this is causing significant psychological the word, psychological distress to this patient, please go ahead and send them because there's medication and therapies to be able to shrink that up. I don't need you to worry about this slide. So you can do your thing. You guys, it's funny, I can watch you guys all do this at once. You go like this, right?
Called swish swish.
Swish, swish? Okay. So the point of this one is to say that gynecomastia's differential is all the things. Right? If you look at this, any kind of drug, any kind of hormone, any kind of cancer, any kind of abnormality with a hormone, any kind of side effects for things, gynecomastia can be a side effect. So that's why it is so important to know, have I put something in there that's telling you it's concerning or not? So hard fixed mass or a discharge. Otherwise, it can literally be anything. Okay, menstrual problems, we get to those. So when Dr. Love was starting to talk about the menstrual cycle, because that's on this test, right? Menstrual cycle, okay. So things to round this out. So once you have those breast buds, so true breast buds in this little girl, so the brain is actually turned on, we're between the ages of 9 and 13, we're doing okay. And mom asks, when is she gonna get her period? From the start of breast buds to time of period is about 2 years, 2.5 years. I always tell families on the shorter side so that they're prepared and that they've had conversations. I say 2 years, but for you provider to provider, the average is about 2.5 years. There should be some concordance between mom and daughter for the most part. When I say concordance, what does that actually mean? Same time, but what does that actually mean then? Like if mom had got her period at the age of 12, when would you expect the daughter?
12.
Or plus or minus a year. Right? So the concerning and why this is helpful is if mom says, I started my period at 11, and you have a 15-year-old in front of you who has not started her period, something's off. Versus, mom said, I didn't start my period till I was almost 16, and she's 14, I'm not worried. It should be within about that year. Then in the first 3 years, you have all kinds of cycle variation. This is new plumbing. This is a new physiologic process. This takes a little while to get going and to get going in a regular pattern. And we'll talk again about what that means. So the first couple of years, a lot of those cycles, if she might have a cycle where there is endometrium that is shed, but if she is not hitting that true LH surge and she's not getting ovulation, they are anovulatory cycles. So you have a lot of those irregular cycles in those first couple of years. Ovulation is typically what's very painful. So if you have anovulatory cycles, do most young girls have menstrual problems right after they start menses? No, it's typically a couple years after. And that's always really confusing to families because they'll say, if she started her period, she was fine, it's been a couple years and now she's not fine. So that should make sense physiologically. Now she's starting to have regular ovulation and that's the painful part. And that's where there's the responsive and more hormone involved. At the start, periods are usually between 3 and the 5-week period, so 21 to 45 days is pretty normal for most little girls as they start. And then it comes down into 45 days at first and longer, and it will come down to that 3 to 5 window. Anytime that you had a regular cycle then for 1 year, and then it is not regular, that is something that is no longer a primary problem, that's a secondary problem. So if you were ever normal for a year, now that irregularity starts, something to think about. So the reason I tell you that, so let's say that a little girl started, as I fall off started puberty at the age, she was a late bloomer a little bit. So she didn't start secondary sex characteristics until she's 12, maybe early 13. Still normal, right? Now that goes for 2.5 or 3 years. Now she's 15, she starts her period. Now in those first 3 years of variation, now she's 18, maybe 19. Whose clinic is she in, mine or yours?
Ours.
She's in yours. She's in sick call. She's at the clinic. She's having menstrual problems and now she's active duty and she's looking at you to say, help me. And now she's in your world, not mine, okay? So that's why, particularly for Army medicine and Air Force medicine, this matters, is because you actually will see them probably more than I will. So, how do you then ask a adolescent or late adolescent some of what is normal? So if you ask somebody, do you have a normal period? They will all answer yes, because that is their normal. So how do you distinguish what is normal versus what is not normal? So first, well, how long between each of your periods is that? A lot of people will have no idea. If they can give you some sort of time frame, should be between those 21 and 45 days in those first couple of years, really should be between 21 and 35. So why does that matter? If somebody comes in and says, I have my period every 2 weeks, you're thinking, well, that's not normal, that's too frequent. Or, I don't know, every couple of months, also not normal. How long? Should be fewer than 7 days. Some sources will say fewer than 8, but should be less than a week. And then you have to ask specifically how many pads or tampons are you going through. I believe Dr. Love will say that it's 5 mils that a tampon or a pad can hold, a typical one. So fewer than 5 in a day, or fewer than 5 to 6 in a day. So if you're thinking about how much is that in a day? So if that's 30 mils, do you remember what 30 mils was? It's an ounce of blood, right? If you're losing an ounce of blood a day, that's a significant amount of blood.
Wasn't it like emails?
Okay, so we're looking at, if you're asking normal, what is the
60.
frequency? So on your test tomorrow, look for your frequency. Is she telling you that it's less than 21 days? You have it too frequent. More than 35, it's too far apart. More than 3 months, what is your most likely cause if there's amenorrhea? Most likely
Secondary.
cause of amenorrhea.
Oh, pregnancy.
Pregnancy, yeah. Yeah, so 3 months, most likely that. Duration, again, less than 8 days or less than 7 days. I'm not gonna trick you between a 7 and 8 days. It'll be periods last 12 or 13 days, or periods are 5 or 4 days. Less than 2 days is also concerning. For some reason, you're not having a hormone response that is allowing you to shed some of the endometrium, something to think about. If you're losing less than 5 mils of blood, again, worried that that endometrial lining isn't shedding. More than 80 is considered a lot. At that point, if you're losing more than 3 ounces of blood, really, in a week cycle, that is gonna be concerning for an iron deficiency anemia, certainly. And then if you're bleeding in between. So these are how you're gonna take a history of a true menstrual history and things that you should watch for tomorrow. She's going to give you some of these characteristics and some of that, what's normal, what's not normal. So different disturbances. So this delayed onset, so 75% of females will have something of either a flow issue, a pain issue, something in them while they're going through this adolescent period. So if you think 75% of patients, they're coming to you, that's a lot of patients. So being armed with some of this information. Most of the time it's gonna be reassurance or a relatively easy intervention. Some of the times where there's significant pain or a significant prolonged flow are very frightening to a patient, and that requires certainly much more management. They have specific gynecologic adolescent providers, and thank God for them, because that is not the area of medicine that I want to be in. So thank the Lord. So amenorrhea, how do we define amenorrhea? 3 months. Yep. Well, how am I defining primary amenorrhea?
16.
16, exactly. Yep. So if you have not had your period start by the age of 16, that is primary amenorrhea. That means that we gave you 3 years from the edge of that normal at 13 to get there, and you still didn't hit it. So at that point, we've given you hit it as late as it could be and as long as would be normal, and you still haven't hit it. So that's why that age of 16. If you have secondary sex characteristics. So, did you start to have breast development? Did you start to have axillary and pubic hair? Have you had a growth spurt? So things to look at. If you haven't had anything by 14, no secondary sex characteristics. So at the age of 14, you still look like you're an SMR1, pre-pubertal. You're gonna go ahead and start that workup because that didn't happen, you missed the first part. versus you started the first part and now you just haven't had menses. Two different types of workups there. If I said the most common cause is premature ovarian insufficiency, what syndrome might you be thinking of? When did we talk about early ovarian failure or ovarian dysgenesis? Yeah, I heard it. I know you guys want to say it. Turner, yeah,
Turner's?
the Turner syndrome. Yep, so this early ovarian dysgenesis. So that could be one of the causes that you see. 14 years old, never had any secondary sex characteristics. Oh yeah, that's early ovarian dysgenesis. A Mullerian agenesis. So do you even have all of the components? Do you have that blind pouch, or do you have that connection where you could even have a uterus that would shed? Is there some other anatomical abnormality? I don't know, is this the block where she did the imperforate hymen? Is this in this one too? Right? Do you have all the structure, you have everything there, and you don't have an outlet flow? So that could be something that you would see as well for this. First is your secondary amenorrhea. Everything was going fine, going along, now it's not fine. So most likely pregnancy. The other big one that we see in adolescents is PCOS. Talk about PCOS. Standard history. Is there something chronic that's going on? So fertility is the first thing to go in chronic illness. So if you're thinking evolutionarily, if you're running from a bear, if food is scarce, if there is something going on, self-preservation is going to be first. So you're going to shut down your ability to reproduce. So that's going to be the first thing that goes in chronic diseases. Is there a medication that somebody's using? I've had people that come in and they're on birth control where they will skip their period and then they will come in because they don't have a period. Sometimes it's just simple education to say, we purposely stopped that, or taking this in a way that you didn't maybe mean to. So something to think about there. All of your irregularity questions, so is it normal, and defining that for the teenager to help them with that. And then a detailed menstrual history. When did mom start? When did you start? When did you first start puberty? To see where you're going. Why am I asking about headaches and vision changes? For tumors, what kind?
Prolactinomas.
Brain, what part? Pituitary. Why does it matter with vision?
It sits right next
It's
to
right
the
there.
vision
What is?
center.
Where does it grow back into? The octave chiasm. Yep. So double vision. Blurry or double vision. They had galactorrhea. What kind of pituitary tumor are you thinking? Prolactinoma. Yep. So what would your prolactin level be?
High.
High. Yep. Changes in your skin. So if you're really dry, flaky, cold skin, hypothyroidism. Your TSH is going to be what? High.
High.
Your free T4?
Low.
Correct. If you see a question where it says she is cross country and runner and she runs 7 miles a day, does 2 other workouts, and she's dropped 20 pounds in the last 6 months, what are you thinking about that? Yeah, an athlete, female triad, right? Again, her body is saying, I have to shut down reproductive ability because I am trying to maintain self. Looking at BMI, again, that female athlete, so they're going to see there's some sort of disordered eating. You have amenorrhea with that, and then you have a loss in that bone density. So she might be doing weights and running a ton, but because her diet is not able to keep up with that, she's amenorrheic. You are seeing some of that osteoporosis as well. For heart rate, if you have that, high or low? We're in a preservation state.
Tacky.
Low.
Low. Oh.
Maybe low.
I
Can see
tried.
estrogen excess. So if you're thinking, I have androgen excess, I have hirsutism and amenorrhea. What am I thinking that is? PCOS. You guys haven't learned, you haven't had that in women's health yet? Oh good, we'll do that today. That's good. So that one is for PCOS. We're looking at that. Eating disorders, so if you see little baby hairs that are starting to form or callous knuckles, that is a sign potentially of binging and purging. For the love of God, again, for young adolescent females, do not do speculum exams, do not do invasive exams. You are doing an external genitalia exam only. If there is no abuse or assaults, that's really the only time that you would be doing anything where you need to look invasively. if you're not sure about the anatomy, it's pediatrics, what kind of studies might you do? Ultrasounds, correct. Do your diagnostic testing for your amenorrhea, pregnancy. It's pediatrics, so I want to see what's going on with our thyroid. Is my prolactin high? So that would stop any kind of period. FSH, to look at is my pituitary functioning. And then only if it's primary do I need that pelvic ultrasound. If it's secondary, I know all the parts are there and they're working. That's functionally what that flow chart says. That's going to be your workup of choice for your primary and then secondary amenorrheas. We'll get to polycystic ovary syndrome. So when you're talking to another provider, this is not, you're not putting the qualifier on the syndrome. So it's not ovarian syndrome, it's polycystic ovary syndrome. Just when you're talking provider to provider. So you have three components of this. So something is stimulating these ovaries to become cystic, but one is not coming out as the victorious champion every month. So you have all these cysts on your ovaries. You have then an excess of your androgens, so hyperandrogenism or hirsutism on exam. So you see all the male type qualities. So more acne, more hair growth, more distribution of weight in different places, and then menstrual irregularities. The thing is, you only need 2 of the 3 criteria to have polycystic ovary syndrome. So you could have and meet the criteria for this without having polycystic ovaries. I always think that is wild to me, but that is the case. That is what you need. So some sort of menstrual irregularity, typically about 3 months, with pregnancy being ruled out. Hirsutism or hyperandrogenism on labs or in the clinic. So if you see somebody who is telling you, I haven't had my period in 3 months, and they have a mustache on exam, you've already met the diagnosis, truly. Or you can do a full lab workup and do an ultrasound, and you meet the criteria that way as well. So there's a lot of different ways to meet the criteria for polycystic ovary syndrome. Oftentimes seen in obesity, so if you see that acanthosis nigricans as well can show an insulin resistance. So you can see that. That's also going to increase those androgens, but not necessarily always. There's a lot of skinny PCOS running around as well. You have amenorrhea. So I did a pregnancy test and they're pregnant. And you just have them go see OB. I did an endocrine workup, something's abnormal. Prolactin, TSH, something's off. Or I did an ultrasound or I did an exam and something is anatomically off. You need to go to gyne. Notice, none of the options say stay at the PCM forever and continue to spin your wheels. Right? This would be an appropriate time to do that workup and to send to that appropriate specialist. So this is not a patient that you necessarily need to hang on and hang on and hang on to, but make sure they get to that appropriate place. What about if it's the other way? So now we don't have no bleeding, we have way too much bleeding. So abnormal uterine bleeding. So this happens in 1 out of every 5. And again, anovulation is going to be an issue where I don't have the perfect signaling. I didn't get that one, I didn't get the spike and ovulatory, but I have this lining that's building up. What is happening there? So pregnancy can certainly be the cause of that. Infection can always be a cause of that. If you're thinking, which type of infections are you thinking might be the most likely to cause this? Is trichomonas going to be your most likely cause of this?
No.
No? What might be the most likely? Chlamydia and?
Gonorrhea.
Gonorrhea, correct. Things that are going to cause PID. Your endocrine disorders, again, this is pediatrics, so thyroid is always that safe choice. PCOS, where you have that imbalance and you can't shed anything, and any pituitary disorders. Malignancy can cause some of this, especially if it is in a gyne type of malignancy. Trauma is always an option. Are they on some sort of contraception? So medications or contraceptions can do this. And then a foreign body. So foreign body is probably the one that I've seen tested the most, where that there was something retained. There was a tampon that was not disposed of properly, something like that, or a part of an IUD. that is left in place. Something like that is the way I've seen that usually tested. Your history, again, is going to be how much flow is there. My exam is the same as the other one, so which SMR stage am I in? Is there any other signs that I have abnormal bleeding? So how am I going to ask about petechiae? How do you ask about, do you kind of bleed all the time? When does that happen? When might you get little micro bleeds?
When exercising?
Not necessarily. Oh, you can see that with certain bowel movements. What are you supposed to do 2 times a day and then we all have to get marked off? Yeah, brushing your teeth. So if you have bleeding when you're brushing your teeth, it's one sign. A lot of times women, you will see this too, if they shave their legs and they have significant amount of bleeding from that. Kind of, do you bleed normally? Do you have a mustache? Do you have acne on shoulders and back that you would not expect that for a female? If you had significant weight loss, weight gain, do you have insulin resistance, and you have a giant goiter or some other sign that you have hypo or hyperthyroidism? Same for pregnancy. I want to know, are you pregnant or not? Have you recently been pregnant? My CBC, if I've had abnormal uterine bleeding, what do I expect the H&H to be? Low or high? Low, correct. What do I expect? You haven't had hemo yet. What do I expect the iron to be? Just guessing. Low. And then your total iron binding capacity is going to be through the roof because it's trying to say, I need more iron. Your coags, you always want to make sure, are you clotting? So what organ does that happen in? Your liver, right? So if not clotting correctly, do I need to check a liver function as well? Always thyroid, always STIs, specifically for gonorrhea, chlamydia. Other things to look at are those male hormones, so your testosterones and then your DHEAS. If I have abnormal uterine bleeding, why do I not need any radiology? I know you have all the parts. I know you have all the pipes. Everything is working appropriately. So not going to be necessarily a structural issue. If gyne wants to get that, that would be something that really, in an adolescent, the gyne would be getting. So you have to figure out how much quality of life is affecting this teenager as well. So I usually ask, how many days of school do you miss a month for this? Or how many times do you miss for sports or whatever their activity is? How often do you miss for this? That's how I'm looking at quality of life for kiddos. If they have that much significant bleeding, make sure that is supplementing their iron because you know they're losing a lot of blood. If you're giving them, what's the easiest way to give a combination of estrogen and progesterone?
COC?
COCs. Yep, oral contraception. Easiest way to give that. A lot of times, we will do that just for a few months, 6 to 12 months, just to regulate the access, to give it time to kind of calibrate itself so that it has a routine. You don't necessarily need to stay on this forever. So that's one of the misconceptions is that if you put somebody on hormonal contraception, that they will have to stay on this forever. If a family doesn't want that, let's try it for 6 months to regulate the HPA access and then pull it off. Sometimes that can be really helpful too. If they have, we'll talk about this and you'll get this in hemonc, something of von Willebrand's disease as well. So they are in a more likely to be bleeding. And this will be, you'll see it in patients, their moms, their sisters, their aunts. So all the females in the family with von Willebrand's. And if they can't take estrogen for some reason, it's obviously going to be a progesterone only. So who can't have estrogen?
People with PEs, breast cancer.
Smoking. Yep, they have a estrogen-dependent tumor.
History of DVTs.
Yep. Who else though? What that Colonel Rogers taught? Migraine with aura. Right? So migraine with aura would be another one where you can't give them an estrogen. So progesterone only for that teenager. You guys need a break? You look like you need a break. Let's take a break. Take 10 minutes, come back. Huh?
Full.
Painful menses. Yep. How many people do you think this affects?
A lot.
90%, yeah. So I don't know who the 10% are, but 17 to 24, again, that's gonna be that young active duty population who's coming to you for the first time, starting to have these painful periods that are now ovulatory cycles. So if you are in that role as the PA advising a commander, this should make physiologic sense to you. They're not making it up. This is new to their bodies. So very painful cramps can accompany this usually before the cycle. Did I put it on there? What's causing this physiologically?
Prostaglandins.
Yeah, your prostaglandins are causing this. Okay, so if the prostaglandins are causing the pain, and we need to give an antiprostaglandin, what are you going to give?
NSAIDs.
NSAIDs. Yep, that's going to be your first line. What will Tylenol or acetaminophen do for you?
Jack crap.
Nothing. Right? Don't pick that. It's not Tylenol. So, in the absence of pelvic pathology, those first couple of years, when ovulation starts, you guys got it, prostaglandins, we needed to get rid of some of those prostaglandins to bring down some of that inflammatory response. You guys already said it, first line is going to be your NSAID, so pick an NSAID, any NSAID. It is not going to be then acetaminophen. Please don't pick that. If the second line fails, then you are going to go into your hormonal contraception. So that's going to be second line. So watch your questions carefully. If I'm saying what's your first line, or this failed, then what are you going to do?
Cry.
No, you're not going to. Secondary dysmenorrhea. So that primary it's painful because that is the normal physiologic process. Your secondary dysmenorrhea is really truly saying I have some sort of pelvic pathology. So most likely that's going to be endometriosis. She taught on that yet?
Yes.
Yep. Where is that?
It's like in the
Outside of the
outside.
uterus. Can be anywhere.
Endometrial
So
tissue
you've seen
invading.
it in the lungs, seen it in the nose, right? What's going to happen if you have endometrial tissue in the nose?
Painful.
Nosebleeds,
nose.
right? As soon as you get that indication to shed. That should make sense to you physiologically. Pelvic inflammatory disease.
Did it travel?
What
there?
is most likely the cause of that?
Gonorrhea, chlamydia.
What do you see on exam for pelvic inflammatory disease?
Strawberry red cervix.
Yep. What's the
Chandelier sign.
Chandelier sign. There you go. There's a chandelier sign. So very, very friable and painful cervix.
That was from Lieutenant Colonel Rogers.
Yeah. Endometriosis. How do you diagnose endometriosis?
Laparoscopic.
Yep. Laparoscopy.
Visualize.
Detailed history and physical, you're going to have gyne as part of this. Is there some sort of respiratory, reproductive tract abnormality? Again, you guys already had that laparoscopy. So same stuff you've already learned. So it sounds like you guys are studying well. So back from the beginning of this lecture before we switch into part 2. What were the exceptions of confidentiality? When, as a provider, do you have to break confidentiality with a teenager?
Hurt themselves or others.
Yep, you're going to hurt yourself or somebody else.
Sexual abuse.
Sexual or physical abuse. Yep, so abuse or self or homicidal harm. What is the first sign of true puberty in a male?
Testes getting bigger.
Testicularity, female.
Breast buds.
Felarchy, yep, breast buds.
Feeler.
If you have primary amenorrhea, primary, it's never worked, and they have secondary sex characteristics, when do you start that workup?
16.
Yep, 16. No primary secondary characteristics.
14.
Correct. You're so smart. Okay. Hard left shift over to the sports physical. Because there's no other real place to put this in, so we'll put kind of in here. If you read your textbook very diligently, this is not in your textbook, this is in your secondary texts that I have a copy of if you want to read that. Probably none of you even noticed that. That's good. Okay. Pre-participation sports physicals. This is not the same as a well visit. So please take that in your mind as a provider. They are not the same. They are similar, but these pre-participation sports physical, I will refer to as just the sports physical, is functionally a glorified musculoskeletal screening and some cardiovascular examinations. So it's a glorified screening exam. It will identify some problems, maybe 1 out of every 10, but it's really only going to stop 1 out of every 100 students from participating in some sort of sports physical. So the yield of this, of finding true pathology, is not high. It's going to stop them from sports, but it's a good time of interaction to look at risk stratification, immunizations, vision, hearing, vital sign exams in an otherwise healthy population that you really don't see very often. So that's why I say it's a glorified screening evaluation. You could put it together with a well visit, all the better, but oftentimes not. And really, what I want you to put in your heads is that I want you to protect your own license and your own career. What some of this is about is to try to put the liability on the provider to say, well, you said it was okay for them to participate, okay? So if there's something that you're like, I'm not comfortable with this for whatever reason, you don't have to sign the form, okay? The liability should not go onto you. You're just saying, and I don't ever say, I recommend that they play. I say, there's nothing today that would preclude them that I can see based on this limited screening. So protect your own license, protect your own practice. Medical history, certainly if there's something big and glaring. A family history, and the ones that I particularly care about is early cardiac. When I say early cardiac, how old? Do I care about great grandma that had a heart attack at 90?
No.
Much as I would love to care about that, I really don't. What do I actually care about?
Young.
Young. When I say young,
Sudden.
what do I mean?
Like.
Under
30,
40.
under 40.
Yep, so did somebody have cardiac pathology in this family under the age of 40? And I even really care under the age of 50. If, I think maybe it's because I'm in my 40s now. If I care, yeah, that's probably why. But if you're looking at early cardiac abnormalities. Any lung pathology, does everyone in the family have asthma? Certainly then that's something to take into consideration. And then musculoskeletal. If you're looking at this basketball player and everyone in the family is 6 feet tall and wears glasses and has some scoliosis, what genetic thing are you thinking maybe they have? Marfan's. Yep. And if they have Marfan's and they are coming in to say, I would like to do this sport or these type of sports, what do you need to screen for? Aortic, yep. And so if they're saying, I want to be a power lifter.
No.
No. I want to do cross country. Sure. Warm up. Yeah, exactly. So this is where you're going to do some of that kind of glorified screening based on some of those other things that you know. So heart and lung exam, absolutely. A detailed musculoskeletal exam. We'll talk about just a couple of other things that you're going to do. This was the big change from probably where you grew up and where I grew up. There are no standard labs. You're not doing UAs, you're not getting EKGs, you're not doing screening echoes. No standard labs across the board. Big change. Checking your immunization reviews, talking to the parents, and then some of that anticipatory guidance. So certainly the Marfan's child, make sure you warm up sufficiently so that you have that connective tissue. Your history is obviously the most important component of that. So is there something that's ruling that out? Did they have heart issues as a child? So that's an important question to ask. And then something on exertion. So if they are having chest pain with exertion, that is a red flag in adults, that's a red flag in children. So chest pain with exertion, big red flag. Short of breath with exertion, that's a provider call, right? How many of you go run a couple of miles and you're like, I feel short of breath, right? Most people, unless you're like a gazelle or something, I don't know. But most people are gonna feel short of breath from participating in sports. So kind of determining, is this deconditioning or is this true pathology and dyspnea on exam? Skip beats or strong heartbeats, I always say, listen to your patient very carefully. We had a patient in clinic who was saying, before I go to swim and I'm on the blocks, I just feel my heart like beating out of my chest. We kept saying, oh, you have anxiety, you have anxiety. The girl had SVT, right? So she was telling us, I have these funny heart rate, and we weren't catching, we weren't hearing what she was saying. So make sure they're telling you what is going on, that you're really getting a good history for that. So some of your things, these are some of your kind of red flags that I'm looking at. So yes, you're doing a vital sign. What I'm looking at specifically, is this patient hypertensive? This is a good chance to check for that hypertension. For height and weight, I'm looking for your extremes. Is this a child with obesity that I can intervene on? Do I think there's concern for female triad or for an eating disorder? I'm really looking for those extremes. For vision, right, can you see? If you can't see and they're gonna try to be on the basketball team or play tennis, it's not gonna go as well, so certainly intervene there. Lymph nodes, this is a good chance to check for any kind of malignancies like that. If you are seeing a child for a pre-participation physical, the answer is to check in multiple different ways. So you're gonna check their heart laying, you're gonna check their heart sitting, you're gonna check their heart standing. So please check in multiple different positions. Certainly lungs as well, we already talked about that. An abdominal exam might just be very, very quick. You're probably not gonna pick up anything on that. Skin is the one that I actually really do care about. Particularly what sport? Wrestlers, what am I looking for? Staph infections, a herpes gladionatorium infection, something on cauliflower ears, something where they would have something that potentially has an infective issue that could spread to somebody else. So depending on that sport, they're going to be touching what other skin infections. GU, do I care more for males or females?
Females?
Well, for on visual exam and for the sports physical. Males, right? This is a very limited opportunity that you have for teenage males to make sure, because they're at high risk of testicular cancer as well. Is there any lumps, bumps, masses? Is there anything with hernias? Is there any concern that is a chance to check out that pathology and make sure that a sports injury would not be making something worse? And then a detailed musculoskeletal, the biggest one is going to be scoliosis that we're looking at there. I think I basically just said all of those things. Focusing on cardiac, focusing on your MSK. Please, again, I don't know how else to say this. Do not do a speculum exam on a teenager, right? Don't pick that on your test next week either. Don't pick it. Start this one. You're gonna need to know this line. So, when are you gonna say you can't participate? When are you that 1 out of 10 that says not today? So, seizures are not an absolute disqualifier, but seizures within the last 6 months are. So active or uncontrolled seizures are going to be a stop, and it doesn't mean that you say you can't participate. That means I can't clear you today. Pediatric neurology needs to clear you. The specialist who is managing your seizures. The last thing you want to do is to have a child get a concussion who has uncontrolled seizures. Now you've complicated that fix. Very difficult to see that pathology then. Of note, I think it's wild though, it's a patient self-reported no seizures, and it's the same for adults with driving. So patients are not supposed to drive if they've had a seizure in the last 6 months, but it's the patient report, which is wild. Should enjoy the road on the way home today. Second thing would be if you had stage 2 or poorly controlled hypertension. So that would be a full stop as well. So that's why that part, looking for hypertension on the vital signs, is of utmost importance. I know that the nephrology test has some PTSD associated with it, as does the surgery test. So if you have stage 2 uncontrolled hypertension, are they gonna go to nephrology or are they gonna go to urology? Nephrology. What's gonna happen if you send them to the urologist? Yeah, you're gonna get a call about why you are dumb. Don't do that, okay? Urologists do surgery, nephrologists do nerdy things, okay, on exam.
Sorry that we thought a
and
scope
then
was in
mono,
surgery.
active mono.
Okay.
So in the first month of mono, so that active infection enlarges the spleen. The spleen takes a lot of blood in that area. You get hit with a contact sport, rupturing of the spleen. So active mono is another one. So these are your big 3. There's a secondary list. This should make sense to you at this point in your education. If you are reading this list and you're like, man, I don't really know why they shouldn't participate in sports with a recent history of concussions and post-concussive symptoms, or with HOCM, or with severe hypertension uncontrolled. If you don't understand something on this list, I truly, from the bottom of my heart, mean this. Come please talk to me. The rest of these should make sense. These are the ones that typically trip people up. So be aware of these ones particularly. When you get to phase 2, so you can all do your little swipey thing that you do all together. I'm not going to ask you about this, but these are just, there's a whole bunch. You're going to see a ton of teenagers with this, so I put a bunch of resources on your phase 2 page for when you get there. Adolescent nutrition. So we talked about baby nutrition. back to a review. When do we start solids in babies?
6 months?
Yeah, 6 months. So it's the developmental stage that they need to be doing in order to be safe.
Hold their neck up. On
And
their
they
own.
hold their neck up and they sit up. And they're starting to do that, correct. When do we switch them to whole milk?
A year?
1 year. What do we do for a screen before we start them on whole milk? Do we check iron?
Allergy test?
What are you actually checking? For anemia, how are you checking for anemia? Oh boy. How do we check for anemia?
CBC?
H&H. Yep. So, or CBC. What's the other screening test that we do at 1 year besides the H&H? Lab draw.
This is on a baby, okay?
Lead.
It could be different.
Lead. Good. What, how long do we avoid honey?
A year.
1 year. Good. Okay. Just making sure it's back there. Did someone say it's not? Oh, lie to me. Tell me it's there. Okay, for adolescents, this should make sense. You guys were all adolescents once. You need more calories than a typical adult is because you are growing. So you have to have those higher caloric intakes. I'm not going to ask you specific amounts, but it's higher than the adult burden. What I do need you to know is calcium. They are growing rapidly. There is bone turnover. They do need the building blocks of that. So making sure that they are appropriate on vitamin D and calcium. So ideally, they're getting 1,300 milligrams a day of calcium supplementation. Things to watch for. Adolescents, they don't oftentimes eat breakfast. So they're typical meal skippers, grazers. They can eat Taco Bell like 17 times a week and be just fine. Right, these are the teenagers who can just have whatever they want, so making sure that they have some sort of appropriate nutrition, but that they're also having nutrition. See, disordered eating often in those sports, that weight is a big issue. So a lot of gymnasts, cheerleaders, wrestling where they're cutting a lot of weight as well. So then how are we defining obesity? So we said before, so really the second half of that between the 5th and the 85th percentile was normal for all of those age kids over the age of 2. So adolescents are the same. 85th to the 95th are considered overweight for your percentiles. 95th and above are obese. It's going to range with that. I'm not going to make you calculate a BMI. So your EHR will help you calculate those. No reason to spend your brain power on that. If you are, and you have a patient in front of you with severe obesity or any type of obesity, a couple of things I want to check. Are they diabetic? So do they have a glucose? Especially we're talking about adolescents. So this is not your little skinny 4 or 5-year-old that has a type 1 diabetes. This is your 15, 16, 17-year-old kid. So do they have type 2 diabetes? What is my glucose? What is my A1C? Do I have an issue with my thyroid? Am I part of that I have PCOS? Things to look at. When we're talking about obesity and weight loss, I do not want any child under the age of 7 to lose weight ever. Ever, 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 ever. They should never lose weight. I want them to grow into their weight that they do have. So I want to hold them steady, but I don't want them to ever lose weight. 7 and above, no more than 1 pound a month. That sounds like a lot, right? If you're looking at adults who are like, a couple pounds a week, right? No, 1 pound a month. And your goal is just to get them under that 85th percentile. I'm not trying to get them to the 50th. I'm not trying to get them to some ideal body weight. I'm trying to get them in that normal range, and then we hold while their body continues to grow into it. SMART goals. So if I told you, hey, just study more for tomorrow. Good goal, bad goal?
Bad.
Is that a SMART goal? No. For pediatrics, if I was like, just no more peds. Just no more. Right? That's what our patients hear when we're like, diet and exercise. What they're hearing is if I said, just no more peds. Just study more, right? If I said, hey, pretend that you like peds as much as I do, and please study for 15 minutes pediatrics every day so that the night before peds test you're not freaking out, that would be a SMART goal. I would encourage you to do that. None of you will, but lie to me. These are examples of SMART goals. Families need this, kids need this. Don't ride your bike more? Can you ride your bike 3 days after school for 15 minutes? Not watch less TV. No TV on school nights. Have less than an hour at a time on weekends. Something that is attainable, something that families can do and is very tangible for them. Flying through the end. There's a lot of sad teenagers running around. So sad and angry, depressed teenagers, very common. That is part of the adolescence where you have surges of hormones. And so you're going to have some of those changes in mental health. Now we've added social media to that normal physiologic process. We've added things like COVID. We've added all kinds of crazy world. We have an epidemic of sad teenagers. So you see a lot of those. One-to-ones, you see males, females alike manifest very differently. The ones that we're looking for, again, I'm not going to ask you epidemiology, but the ones that we're looking for are the sad teenagers who are actually bipolar. So 20% of these sad teenagers actually do have some sort of diagnosis of bipolar. And that's what we're trying to really tease apart. Is this normal physiology, normal part of adolescence, or is this pathologic disturbing function? And I really think that this is part of what's going to be considered bipolar someday. The other part of this is suicide has become an epidemic. Don't need to necessarily tell you that. You're all in the Army and Air Force or Navy where this has been a big hot topic for years. We have a lot of young soldiers, airmen, sailors, big problem as well too. What is that, probably from Major McCampbell, what's the biggest risk of suicide attempts? Previous attempts. Yep, absolutely. So if you had an attempt, you're much more likely to attempt again. 30% of all of these teenagers are attempting. Remember, if you're thinking at the beginning of this where it's very concrete, if they haven't gotten to that next layer where there is a tomorrow, they can think about the future. Not everything is the worst thing. Makes sense why, particularly in those teenage years, they're at this high risk for suicide. Some familial, certainly part of it. We see it in twin studies. You guys have all learned all the sad stuff that is going to be those psychological things that make you more at risk. The ones I look for are the protective factors. Because I know all kids are going to go through the hormones, all kids are going to feel some of those changes. I'm looking for protective factors in clinic and when I'm interviewing somebody. So do you have friends? Do you have some sort of a group and connection? Do you have an older mentor, a grandma, mom, dad? Do you have an older adult in your life? Do you have aspirations? So those are the biggest three things that I'm looking at. Do you have a plan? Do you have some sort of friends? And do you have an older adult? So those are the three protective factors that I'm particularly looking at for these kiddos. Oh yeah, way back from Major McCampbell. SIGGI CAPS. What does it stand for? What's the S? Sleep. What's the I? Interest. When I say interest, what does that actually mean? Yeah, change. They don't want to do this anymore. I used to love ballet, now I hate ballet. I don't want to go anymore. I was into soccer. Who cares about soccer anymore? What's the G? Guilt. What does that look like? What does that look like in a teenager?
Are teenagers capable of guilt?
Yeah, they really will take on guilt. So you'll see this, the classic example is a divorced situation where the kid will think, this is all my fault. I ruined my family. I hurt my family and they divorced because of me. You see that? It's a classic board question you'll see. Say E. Energy. What do you typically see with that? Low or high?
Low.
Low. Yep. Caps.
Concentration.
It's kind of funny. Difficult concentrating. Yes. So difficult with concentration. A.
Low appetite.
Appetite. Which way does that go? You can go either.
Oh, yeah.
With adolescents, you'll see either overeating or undereating. P. Heard it.
Psychomotor.
Psychomotor. Agitation. What does that mean?
Restlessness.
Yeah, you're kind of restless. You can see that a lot. Just kind of restlessness. Is there a second one? Yeah. Oh, suicidal thoughts. I was like, what's the last S? Yeah, suicidal thoughts. So, reminder: if you see these in question stems, trying to give you that they're depressed. This one is really sad to me. The data changed in 2021 after COVID. So for my entire career, The leading cause of death in teenagers was motor vehicle accidents or ATV accidents, any kind of motorized vehicles. In 2021, the leading cause of death became suicide for teenagers. So that should be a big wake-up call for us as providers. You guys already nailed it. The biggest risk factor of a suicide attempt in the future is a past suicide attempt. Things to look at: is there been something going on at home? Has something changed? Death, divorce, deployment, something to that effect. Personal or family history of suicide or psychosis, things that are going to make it more likely. And then handgun. Do they have access to handguns at home? So something that I always think about in a military population where the prevalence of that is just going to be a little bit higher. Do you have a gun safe? Is it locked? Is the ammo separate from the gun? All that does, they still might have access to it. It just slows them down. And if you can slow somebody down for even 10 minutes, the likelihood of following through with completion goes significantly down. So 10 minutes, just slow them down. Your suicide and depression screening. How many of you were medics before? So a significant portion, you probably saw the PHQ-2. That's your screening questionnaire. This is the same for adolescents. So the screener is the PHQ-2. The longer version, the PHQ-9, is a series of 9 different questions that target different anxiety and depression. Your scores come out into none, mild, moderate, severe. So you can kind of delineate how bad is this. This gives you objective data as they continue to come back. So depression, anxiety, or depression screener, and for suicide is your PHQ. If I said, what is your screener for autism? Not that one, not yet.
There's an acronym.
Here it is, MCHAT. MCHAT. What if I am screening for ADHD?
Same.
That was the Vanderbilt. Yep.
Vanderbilt.
Correct. And now I'm screening for depression, so I'm looking at your PHQ-9. For depression, so you're going to go in your page rotation, you're going to see a ton of different off-label things used. That is the way people practice. What is in your textbook and what is testable for your pants is that for depression, you can use fluoxetine or escitalopram. In life, what you're going to hear, Prozac and Lexapro. So fluoxetine is Prozac, escitalopram is Lexapro. Those are your two that you can use for depression. Their black box warning has been on them for as long as I've been in medicine to say, you might get your energy back before you feel better. So that's where that increased suicide risk is coming from. And I need to follow these kids up routine, like very, very frequently. So I usually will have a tech or a nurse call later that week or within a week. Are you tolerating the medicine okay? Because what's the biggest side effect of this? The GI side effects that you see with SSRIs is mostly what's going to get most teenagers. Older adults will have some sexual dysfunction as well, but for the teenagers, you'll typically see GI. And the best is when you can combine CBT or some sort of therapy plus your SSRI, so that combination therapy. You can do a safety contract. It doesn't mean that they have any increased necessarily amount of safety. Again, you're just slowing them down. Who would you call? Then who would you call? Then who would you call? Just to try to make them think, slow them down. For anxiety, how many of you feel anxious for your test tomorrow? Okay? So anxiety is a protective factor. Anxiety helps us do things. If you weren't anxious for your test tomorrow, you wouldn't study. Okay, so what we have to do with kids is what part is protective versus when it is absolutely just destructive and is destroying your quality of life. So we got to find that in between where you can figure out how to do life without falling apart and losing the ability to function. You guys all know what anxiety feels like at this point, certainly. Uneasy, excessive rumination, apprehensive about the future. Sounds like a day at ICAP to me. I don't know, but I guess I'm speaking for you. It sounds like that. What am I looking at? Oh, the different types. So different types of that we'll try to tease apart with kids. Is this general and you are anxious at soccer and at school and at home and to talk? Or are you just specifically anxious about school or specifically anxious in this one particular setting? Selective mutism is a really interesting one when you see this as well, because they just will not speak. So. Your scared form is your screening form for this one. So scared, the screen for children-related anxiety disorders. And that's going to help you break down all of that to see, is this generalized? Is this one specific environment? Is it a specific phobia? Where am I really seeing this? And I do not know why I put this in such small little writing, but your mainstay of treatment for this, again, CBT, sometimes exposure therapy, and then your medications are, again, fluoxetine and sertraline, so Prozac and Zoloft. So if I don't know if there's some anxiety and or depression, what's going to be my go-to medication?
Fluoxetine.
Fluoxetine, because it can treat both. Okay? So that's why for pediatrics, your go-to medication is going to be fluoxetine or Prozac. Really easy dosing too when you get to phase 2. Really easy. So fluoxetine is your going to be, I mean, you can use the other ones as well, but fluoxetine will cover both. And last but not least, your substance abuse. So a quick word on that. Kids use drugs sometimes. So being aware of what they're using, knowing how to talk to them, being able to know what's happening with them. A lot of times it is more males than females. However, you're seeing a rise in females in general. If you're going to start something, a lot of times this is going to start in the adolescent. It is rare that you're going to see somebody who's 30 years old suddenly start drugs. Yes, that could happen, but it's going to be less. So you're going to see this start. We have a whole other lecture where we talk about different drugs, so I'm not worried about this one. Again, remember, gynecomastia can be a side effect of some of these drugs, so things we're going to see. Screening for this is craft. So make sure that you at least know in general what the different screeners screen for. So if I ask you, what is the Vanderbilt versus what is the NCHAP versus what is ASQ versus what is the PHQ-9? So a general idea of what all of these are screening for. So the craft is going to look at, do I have issues of substance abuse? So for alcohol or for drugs, any kind of substance abuse with this. And this is really looking at their functioning. So not just are you doing this, but at some point is your functioning impaired. You can do labs for this, so you can get urine and blood. You will see most often that parents will come and they will demand that you drug test the child. And I caution you, you can order a tox screen for a teenager who might be on something. You're going to lose that therapeutic relationship with the teenager if you do. So be cautious, and I have the conversation with parents. Even if I order this, I cannot hold your teenager down and make them pee in a cup. I don't know how that's going to change my management other than having a conversation with the teenager. So practice how you want to, but keep that in mind that what am I going to do different with this lab? Am I still going to offer this teenager resources? Am I still going to risk stratify? Am I still going to offer potential rehab, things like that, even if I don't have this lab? Absolutely, please understand. Family, so they have family counselors as well. So it's usually when I recommend that the whole family goes to counseling, not just the teenager. Okay, let's run through the screeners. So, the substance abuse screener, real short-term memory here. Craft. What are you doing for ADHD? Vanderbilt. What are you doing if you're looking at the 5 realms of development of a young child, 5 and younger? Ages and stages. The ASQ or the SWIC. Survey young child. What am I looking at for depression? PHQ-2. And then if PHQ-2 is positive, PHQ-9. What am I looking at for anxiety in kids? Scared. Yep. What am I looking at for autism? The MCHAP. Yep, you guys got it. Okay, what can I use to treat depression? Fluoxetine and depression. Escitalopram. Yep, what do I do for anxiety? Fluoxetine and sertraline. Okay. Yes, you need CBT. See symptoms improve in a couple weeks. We did it. Questions, comments, concerns, anxieties?
All of
You
them.
guys all look like you want to die right now.
Week
With
3
that,
of
I'm
5
like,
o'clock
how
days.
did you? Okay. We're okay. Happy to be here. Yeah. Is there something that, can I help at all? Can I take something and elevate it? You guys literally look like you want to die right now. Are you? Send help. Okay. Sounds good. Okay, well then I'll stop talking